So after Dr. Rivers helped establish early goal-directed therapy, he got on the map and got noticed in 2002. There was launched the Surviving Sepsis campaign, and it was an international collaboration among many physician and physician groups that were trying to find ways to raise awareness and standardize protocols and use evidence-based medicine to find what things would work in treating sepsis. And they made this goal, great goal, to reduce mortality to 25% by 2009. And now we are here in 2013, and sepsis mortality is still at 30 to 50%. So let's go over some of the goals that they were reaching for with early goal-directed therapy. We see here again kind of our picture of our patient, what's happening on the inside, usual stuff going on we talked about earlier. One of the first things you want to do, ABCs, is stabilize respiration. On every patient, you want to make sure you get a pulse ox. You might want to get an arterial blood gas, and a lot of patients you're going to want to have on at least some form of ventilation. Typically, a lot of patients have to get intubated because of acute respiratory distress. It helps to also limit their oxygen consumption. They're not working their lungs as hard and not consuming as much oxygen for their lungs. They have more oxygen to expend on the rest of the body. And so that's kind of the idea, is to make sure they're getting enough perfusion. Also, they often have an encephalopathy, altered mental status, that makes it difficulty for them to breathe, and you definitely want to protect the airway. So consider ventilation as an appropriate thing to do. You want to also notice that 95% of their arterial oxygen should be about 95%. After you do that, you want to assess their perfusion. A lot of patients, you're going to want to first initially try crystalloids to resuscitate them. And this is why they're in septic shock in the first place. Septic shock is, again, shock that's not improved despite fluid resuscitation. You're going to want to monitor these patients with central venous, the CVP of these patients. And you're going to want to do that for a central venous catheter. Typically, you're going to want to put in a central line or an IJ line. And I've had to put a lot of these in patients, and it's not really a pleasant experience for them, usually. You want to typically have their CVP be about 8 to 12. And that's because you want to have a little bit higher. I think it's about, I want to say 3 to 5 in most people. And patients have septic shock, you want to have it elevated. Sometimes higher, 12 to 16 on patients that are intubated because of the increased pressure that is on their CVP due to the intubation. With these patients, you want to make sure that they also are having their SvO2 or their central venous oxyhemoglobin saturation monitored. This is going to be one of the important numbers. You can typically correct the CVP with fluids. This is a number you can't necessarily correct with fluids always. You have to try other measures to keep it in the right place. Another thing you want to monitor is a lactate. Lactate is a measure of perfusion. If tissues aren't being perfused well, they're not using oxygen to produce their energy, their ATP, and so they're producing it anaerobically, and producing lactate is a byproduct. A lot of lactate can cause metabolic acidosis, which can decrease the efficacy of some medications that you give patients. So this is something you kind of want to observe to evaluate, not just for their hyperperfusion, but also for how well medications may be working for them. And there's our little IV there. You constantly might have to give fluids to the patient to maintain their balance. So you compare these two numbers. 95% is what the blood is oxygenated at, then it passes through the organs and it's expelled, and it's often less than 70%. So we want to prove that by, first of all, mechanical ventilation can decrease some of the oxygen consumption for the patient. You also can do pressors. You kind of want to redirect some of the hemodynamic failure that's happening in the patient. And you want to try to tighten up those areas with pressors. One of the favorites that's typically used is norepinephrine or Levophed. It's recommended for most of your patients. You can try, I don't have it on here, but vasopressin is an adjunctive therapy you can add on in addition to Levophed at the same time for some patients. These will be continually infused in the patient at a certain rate. and you'll have them be monitored. You might want to put an art line in the patient so they can get dynamic blood pressures on them, rather than having the blood pressure cuff inflate and deflate every 4 minutes. You can get it automatically. The big number you're looking at is the mean arterial pressure, the MAP. You want to keep that at above 65 millimeters of mercury. So there's our levofed right there, and we want to keep that on board into our IV. And you see how that affects the body and what happens after you have it there. Hopefully you want to have the vascular start to tighten up a little bit. You can actually see this on some of your patients that are how impressed their skin will become really cold where it was really previously warm before, and you'll see this kind of malted skin where the skin's really white with some red patches in it where the vessels are just clamped down tight from being on these pressors. Now sometimes you might not reach your goal. If you do at that point, great, you're done. You give them enough fluid, you put them on pressors, you just have to monitor them and make sure you get the right antibiotic in place, and hopefully they'll be okay. Sometimes it doesn't work though. Sometimes there's other problems you need to assess. You can do all these things and the patient's still not doing well. And so something else you might want to consider is the heart. When this happens, sometimes where patients have an increased heart rate in sepsis, they can have eventually tire out and have a bradycardia or have a decreased cardiac output. When this happens, you want to assess that and give them inotropic therapy. And typically what they often use is a dobutamine. It's something you can give a patient to increase their cardiac output and make sure they're giving enough output so they can perfuse their organs. Something else you might want to consider is their RBCs. Patients can have coagulopathies or have bleeding or other symptoms that might decrease their red blood cell production and or have red blood cell loss. When you have a hemoglobin less than 7, it's probably a good idea to transfuse the blood for the patient. That way they can have enough red blood cells to deliver oxygen to the rest of their organs. Another thing you want to do is protect the body itself by cooling it. Most of the time in the ICU when I was there, I'd see nurses try to get this thing, it's called an Arctic Sun right here, and they try to throw it on the patients. The doctor would always come by and always take it off and tell them just put some cold, wet washcloths on the patient. He said they work just as well. You can do this. You can also give the patients Tylenol. Sometimes you can crush it down their NG tube if they're ventilated. And it's a good idea to just keep the patient cool, monitor them, monitor their fever. One of the most important things you want to do is give them antimicrobial therapy. When you first notice that a patient is having this kind of sepsis picture, whether it's in the ER, whether you're just on the floor, you want to get a blood culture or any type of culture, at least in the first 45 minutes. The ones to consider are blood, urine, sputum, cerebrospinal fluid, peritoneal fluid in some patients, wherever you think it's most likely to be infected. And just be aware, sometimes during the patient stay in the hospital, the infection can change. Our patient she initially had pyelonephritis, and then after that developed some pneumonia, hospital-acquired pneumonia. You want to initiate antibiotics within an hour. Just start empirical antibiotics. Consider broad spectrum with something that covers MRSA for your patients that have possible nosocomial infections from being in nursing home facilities, being in the hospital, or people who are immunocompromised. Also consider antifungals as well. That can also be something that patients can have, or different viral pathologies. You want to adjust your antibiotic treatment as soon as you get to cultures and sensitivities. Even if the patients are improving on what you had them before, you still want to put them on whatever the result says they're sensitive for. This is the only primary intervention that we have. Everything else is kind of just a band-aid to cover up the symptoms. This is what actually is going to cure the patient. So you want to do this as quickly as you possibly can. Another thing I didn't really mention here was giving steroids. Patients can often have adrenal insufficiency due to decreased perfusion to their adrenal gland, and as a result they'll need some fludrocortisone given to them. Often you give this, I believe it's 60 milligrams 6 times a day, and it's something that's not always recommended in patients, but if you're not achieving your desired result of SCVO2 of greater than 70, you want to consider fludrocortisone as something you want to give to your patients. A lot of doctors just throw it on automatically. In the ICU I saw that. Usually it's something you want to reserve for if your initial therapies are not working.